Margaret. Thank you for the invite to come here. I'm normally used to going to conferences in the Airport Convention Centre in Birmingham in the UK. So coming here was a lot different. I've actually dressed up and I've got rid of the shorts because I thought I might be on camera. So my name's Colin Truesdale. I'm the Evolve Product Marketing Manager. So probably the first thing to say about me is I'm not clinical. I'm not a clinician. I was coping quite well yesterday because most of the slides were just sort of, oh look, there's a little red dot of a slide, and that wee red dot's turned green, and that was okay. And I was doing all right. I was doing very well up until I got to Christine's session, which was colons and insides of people. And at that stage, I sort of looked at my shoes for quite a bit of that session. So I work in the nice clinical, sterile world of computers. So I work for Kainos Evolve. Let's get the who are Evolve out of the road to start with. So our main product is what we call the mobile-enabled healthcare platform. In other words, get all of your information, maybe from different places, make it available wherever you're doing care. So whether that's in a clinic room, on a ward, out at a patient's home, it doesn't matter as long as it's made available via mobile means. So we're working in about 80 plus hospitals across the UK, about 50,000 users, managing around the records for around 10 million patient records, which equates to about 1 billion patient documents across those patient records. And we have been quite successful. We're now in about 70% of the electronic medical record market within the UK. And for us, our main mantra is, let's just make things easier. Let's use technology to make things easier for clinicians and to support the care of millions of patients, as you would expect. So now that we've got that bit out of the road, let's actually talk about what I'm here to talk about. Healthcare version 1 is what we've been used to up until now. And it's been, in some areas, quite slow moving. So yes, the treatments have progressed, and certainly when we look yesterday at the treatments for the cancers and everything that's going on in pathology, there's a lot of really good, really interesting work going on there. But actually the delivery of that care hasn't changed that much. A patient has to come into an outpatient clinic. They have to come in for an elective surgery. Somebody then may go and do follow-up care at that home, that patient's home, or as Damien was saying yesterday, they have to come back in for dialysis and all that sort of stuff. So that model of care hasn't really changed much, and so it's been relatively glacial. Also, we've had the mix of the big systems coming into play, so those big electronic patient record systems. For some organisations, they work really well. For other organisations, not quite so, because they find that the pace of change is slower than what they need. So for example, when a new set of standards comes into play from the Department of Health, it may take a certain amount of time for those big EPR vendors to actually catch up and make those screens, make those data capture methods available. And so the pace of change is outstripping the pace that actually healthcare 1.0 can go at. This has also been compounded with a very changing healthcare landscape. There are a lot of different things nowadays that healthcare providers need to be thinking about. They need to be reducing errors, they need to be upping quality. The organisations themselves have changed. So talking to Damien last night, if you think about 20, 30 years ago, the chief people in the organisation were the consultants. On that board of the hospital, it was mostly clinicians and consultants, maybe with a chief exec officer. And that's changed quite a bit. Healthcare organisations have become more business-like. You've got your chief financial officer, you've got your operations officers, you've got your exec officers, and then you've maybe got a representative on that board who's a clinician. So the organisation structures have changed, whoops, as he pulls out his HDMI lead. So that's a lesson for me to stand behind my computer and not move. So the organisations themselves have changed in the structures. There we go. And so they are at pressure to improve their financial results, to reduce their costs. There's more and more government requirements coming into play around how those organisations report back to the government about their clinical outcomes. You've got now the friends and family tests. In other words, would I, as a patient, recommend this organisation to my friends and family? So there's changes coming from all sides to the healthcare organisation. We've also got to marry that with the actual population, and the people that those organisations are serving are changing quite dramatically as well. So people are living longer. The shift in the types of disease is obviously changing then towards those more long-term chronic diseases. We're more increasingly living in urbanized centres, so in big cities, but that's then left a big deficit for rural citizens because all of the healthcare cost and all of the healthcare attention then is on these centres of population. We've got massive clinician shortages. I'll show you on the next slide. It's getting worse, especially in primary care physicians. And the problem here is that if I can't see my GP back at home, what am I going to do? I'll go to the emergency department. And so we're seeing, especially in the winter in the UK, emergency departments are just buckling with the number of people who can't get an appointment to see their GP and are just going straight to the ED. The way that people expect to be treated is also changing. So you've got Dr. Google, our best friend and our worst enemy, as the worried well. I have a sore elbow, I go to Google, it'll probably link me to the Daily Mail, which will tell me I've got cancer and I've got a week to live. That's the world that we live in. So people are changing in how they're accessing healthcare information. They're increasingly aware of what's going on in their treatment, and they're increasingly demanding in terms of being aware of what's going on and being able to interact with their clinician. The rise of social media, that sort of way of, it's my healthcare, I want to be involved. So it's all becoming more and more digital. So how do we do this type of change when we're very much hobbled by our information practices to date? Up until now, information has been on paper largely, or on old siloed systems. Everything needs to start coming together to work together for the patient care. So if we look at those physician shortfalls, they reckon, estimate in the US, that in the next 10 years, by 2025, there's going to be, worst case scenario, they reckon around 110,000 shortfall, most likely between 46 and 90. But in primary care, in the GPs sector, they're working between 12,500 and 31,000 shortfall of GPs. And as I said, if I can't get to my GP, I'm just going to go to the next point of access that I can get to, most likely the emergency department. The big problem there is that the emergency department is the most expensive place to treat somebody. So there's a lot of downstream pressure. And the reality is that we need to start moving at a much faster pace. So we've got rapidly changing populations. We do have increasing amounts of innovation spending. So in the UK, in the aftermath of the national programme, instead of the government saying, here is your big EPR system, your monolithic hospital in a box system, the national programme has now become a funding mechanism. So you have the Nursing Technology Fund, which is a lot around dictation, a lot around mobility. You have other tech funds and other pots of money that are becoming available. So the government is becoming switched on to helping healthcare organisations and their providers innovate. And so this has led to the rise of a term called virtual medicine, or healthcare 2.0. Virtual medicine really being information is wherever you need it. You can treat patients wherever they are, either in person, using a mobile device, or you can actually treat patients remotely, having them dial in via Skype or some similar method. So virtual medicine is seen as disrupting healthcare delivery, so it's going to change how we do it. It's going to lower costs dramatically, we'll see that in a second. It's going to improve the outcome because it's doing smaller amounts of checks more often. So it's little and often, constantly keeping a check on the patient, being more aware when that patient starts to deteriorate and being able to take intervention steps earlier. It's going to allow greater access, so the patient isn't going to have to come into hospital just to get their blood pressure checked or whatever, so the increasing uses of devices in the home. And obviously then it's a lot more convenient for the consumer, for the patient in this particular case. So it's about consumer engagement, so it's about reaching out to the patient. It's about being more proactive and being more consistent and constant in their care management. It's about reducing cost because, let's face it, in the pressures of today, we've got to have a cost model in there. But it's about having very different healthcare delivery methods and models. And these are the models that haven't changed in the last decade or so, in the last couple of decades, but are now changing considerably. In practical terms, It's powered by remote access, so access to that information wherever you are on a device that actually can work with you. And most importantly, it's flexible joined-up systems, so it's not having all of your information in one disconnected bucket. It's being able to move information across systems, so from your pathology system like Cirdan into the patient record and back again. So what are the main reasons behind virtual medicine? Economics, absolutely. It drives down the cost of care. It provides better access for everyone, even if I'm in a very rural setting, the ability to have remote care and have a physician actually do a remote checkup on me. Much easier way to get that care. It's much more convenient for me, obviously, then. And it does have significant benefits in terms of the clinical outcomes. So in terms of some numbers, because I'm a computer scientist at heart and I love numbers, so they reckon that today the virtual medicine remote care market is worth around $250 million in the US, so it's not small money even today. But within the next decade, that's going to grow to around $20 billion US. And it's probably going to top out at around $50 billion when long-term chronic population health programs are brought online as well. And in terms of the numbers, they reckon that they will reduce the number of unnecessary ER visits by 95%. So if you think about the headlines in the UK last winter, it was all about ERs are absolutely failing to cope with the demand because there's not enough GPs and it's pushing all of that care downstream. So if we can start reducing that load, that's going to be massive benefits. So they reckon we're going to replace around a third of all ambulatory physician visits. In other words, ambulatory physician being in-home care. So an outpatient clinician going into the community to the house, that can also be reduced. And they reckon it's going to save around $20 billion. So not small numbers, massive opportunities to use technology to start driving down cost, to start improving patient care in a model that actually suits the patient, that is less invasive into their lives. And when you look at the cost of providing care currently, so the estimates say that a hospital ER visit costs the healthcare system around $1,200. But if we can replace that visit via a virtual visit, so somebody being able to start a teleconference with a remote physician, showing them the rash and then being able to go, do you know what, that's just a heat rash, put calamine lotion on it, something like that. If we can start replacing those interactions with interactions that make sense, there's a massive amount of savings and a massive amount of money can be released back into new treatments, back into new therapies for the patient. And so they reckon that in terms of cost savings, a slightly lower number here actually, they reckon then another study said that it was about $500 for a low emergency ER visit, so a standard ER visit, and savings of around $40 to $44 billion per year. And we are seeing a definite trend towards this already. So today, they reckon, the studies have shown that around 7% of all care is currently delivered remotely. Now, by remotely, this is the stuff that's probably been happening for several years. This is just phone conversations. This isn't the fancy teleconference stuff. Phone conversations would also be lumped into the remote bracket. So remote has been happening for a while, but what we're seeing here is that it's gathering pace, and that by 2020, that'll go up to around 15 to 20% of all care. And so it is starting to eat into a lot of the acute care provided in hospitals as well. So the big question really is, this is all nice in theory. Yes, we're all bought into the numbers. We're bought into the increasing patient care that can be delivered via remote means. But how do we actually, in practice with technology, do this? And from our perspective, there's 4 things. So we need a bimodal healthcare IT delivery model. Bimodal simply meaning that the way that you access the information is as important as the information itself. We've got to free the information up and not have it in lots of different siloed systems. We've got to be able to respond to change so that when the government comes out with a new set of targets like they did 5 years ago in the UK for VTE risk assessments. Well, we've got to be able, within weeks, to respond to those changes, to capture that information, to share that with the right people. And doing that with traditional systems like paper, like the big traditional EPRs, can be very challenging. We need the tools that allow us to re-engineer. We need our information to be joined up and comprehensive. Comprehensive doesn't necessarily mean all in one bucket, but as long as those different sources of information can talk to each other. And crucially, we need a wider team of people involved in the care of the patient. So talking to Damien last night, he said that really the care team for the last 30 years has been the consultant's secretary, and the patient. That's not the case going forward. You've got to have your outpatient workers, you've got to have your home workers, all having access to good sources of information. It's not good enough that my wife is a community physiotherapist back in Northern Ireland, and the amount of information that she has access to and takes into the patient home is very, very small. But she works as a palliative physiotherapist, and so she would actually benefit from seeing the wider patient record. So we've got to have everybody involved and clued in and plugged in to the patient information. So for the bimodal healthcare IT delivery model, basically what it boils down to is you've got all of these different sources of information. So you've got your electronic patient record, your imaging, your electronic health record or EDM, so the scanned paper records that we would traditionally have. You've got your pathology and your radiology system. Those are still going to be around and are still vital in this particular model. But increasingly, just as important as the sources of information is how you're going to actually access that and who is going to access that. So making it available wherever you are. Telemedicine, the ability for me to, at home, plug in a blood pressure cuff onto my mum's iPad and have that automatically upload into her patient record. Wearables are absolutely exploding. So Apple Watch, taking my heart rate every few minutes. All of the studies that Apple are doing with ResearchKit, where as a patient, I can then join a study, which is then uploading my stats constantly into the Apple studies. All of that should be then flowing into my patient record, and it should be accessible via me. So the information is just as important now as, or rather how we access that information is just as important as the information itself. It's no longer good enough just to have several big silos of information that can't be accessed at any one time, that I have to find a computer to log into, that I have to open the application, that I have to log into the application, find the patient, find the information, taking 10 minutes to do all of that. It's no good. We've got to bring everything together wherever the care is taking place. So the second one, we need to be able to re-engineer and work with the changing standards of healthcare and the changing healthcare market. So Gartner did a really interesting report recently about how things are changing. So towards the middle of the diagram in the blue there, you have pretty much the status quo, which is all around in-person care. And so currently the nature of the service is that the clinician is very much present with you. But it's changing. So it has been changing recently to connected care, where I can pick up a phone and call in the UK, I can call NHS Direct and get some information there, and they'll maybe signpost me on. But it's increasingly then going to become remote, where I can do a teleconference with my physician, show them what's up, and get some information back. But it's increasingly heading down towards the lines of the not involved at all, where the systems are using machine learning. So it's what you were talking about yesterday, Malcolm, isn't that correct? About machine learning to be able to say, well, look, based on your results, based on what the machine knows about this care pathway and what is appropriate care, starting to actually make clinical decisions, make clinical suggestions for the care of that patient. So the nature of the service is turning from very much procedure-based. If the patient turns up at the surgery with this symptom, this is the pathway that you put them on, this is what you do. It's now changing in that the systems then are able to spot trends and make suggestions to the physician. And ultimately, it may head towards the direction that care is much more automated for the very standard cases. We put you on an automated care pathway. The system is monitoring your inputs and making suggestions to you, the patient. Now, there's a long way to go there in terms of proof of safety, proof of efficacy, but it is starting to move in that direction. And then the patient location, very much hospital-based at the minute for my inpatient and outpatient clinics, moving towards urban and rural settings. So moving out of the urban setting into a rural where we maybe have a hospital as a small base where people can come into, in towards the patient home, and then really ultimately care is going to be deliverable anywhere. And again, underpinned through mobility and access of that information wherever you are. So it is changing, and what we're seeing is that the pace of change is picking up. And so by 2020, in 5 years' time, the Gartner reckoned that 60% of every business process, clinical business, ordinary business, whatever, 60% of all business processes will be optimized for mobile, which means that they've been built from the ground up for mobile. But what we reckon is that the other 40% will be mobile enabled as well. So increasingly, we're seeing use of mobile. From my personal experience, we started off Evolve 6 years ago, and Evolve is browser-based, and that was the main offering. We then introduced Evolve for iPad, and it was always seen as a sort of secondary thing that maybe trusts will buy, maybe not. In the last 18 months, 2 years, that's completely changed in that they are all wanting mobile solutions, and they'll use the desktop sort of, kind of, maybe, but they all want to use mobile first as a way of accessing that information. So it's no longer good enough for me as a clinician to be sitting like this with the patient here and sitting typing at a computer and then looking up and typing on a computer and looking up. You can do much more personalised, much more approachable care with a patient if we're both sitting with an iPad between us and we're both looking at the screen and we're both able to look at the information and actually make comment on the information. We've seen that our customers are doing re-engineering of their actual physical clinical rooms to make medicine a lot more approachable, essentially, for the patient. And again, it's down to how you access that information and how you collaborate on that information. So the third pillar, we need access to joined up, comprehensive patient data. And so IBM have said that everything is being reinvented. So everything nowadays, all the new systems, and especially the systems that are being very disruptive in their marketplaces, are coming with an API, a way for other systems to talk to them, to get data in, and to get data out of those systems. So it's no longer good enough for my big shiny system to stand completely on its own and can't talk to yours. It's what Ronan was saying yesterday about the dashboards. So we need to be able to get information out of one system, marry it up with information from another system to get proper insights across the data landscape for the patient as to what's actually going on. Systems that don't have an API, that don't talk to others, are now getting a bad reputation in the market for being standalone, and it's actually starting to work against them. We've seen that in several procurements recently in the UK. So we're doing a lot in Evolve on working on standards like HL7, but if you've heard of FHIR, Fast Interoperable Healthcare Resources, it's the new generation of interoperability for systems. It's much easier to build against. And in fact, I've been on a bit of a world tour this past couple of weeks. I was in Toronto 2 weeks ago, and I was at a high school, or a technical college rather, and they actually had a group of students that were building medical applications using the FHIR standard because it's so simple. And they were showing me applications that had a little Bluetooth beacon outside a shop. And when I walked past that shop, it would say, okay, there are treatments available here. This is actually a surgery. Would you like to register? And I could register from my phone, go in, get treated. They would have access to my patient record, all because they've got very easy to use interoperable standards. It's the way the world is going. So it's no good to say, I ain't playing anymore. You've got to play in the market or you're going to be left behind. And so in the same way that we need all of the systems to collaborate, we need all of the care providers to collaborate. So this whole idea, this whole lofty ideal of virtual medicine only will actually work when everybody is connected and working together as a team. So the healthcare organisations that are going to succeed, and if you think about the UK NHS is all supposed to be nice and collaborative, but really remember that all these different trusts are kind of competing for patients in the same patch. Well, the ones that are going to get the patients are the ones that can collaborate right the way through from that patient initially going to their GP, through to a strong referral, through to good triage, good treatment, good outpatient care for follow-up, through to the home, with all of those people being well informed, because nothing annoys a patient more, and I've experienced that with my dad, nothing annoys him more is that every time he sees a new face, even four or five different people on the same day, having to ask the same number of questions and answer the same questions time and time again. In the NHS, you've got the Tell Me Once initiative, which is just that. I should only have to tell you my information once, and it should flow through. I think it was Ronan yesterday was showing that I should only have to put in my information once, or it was Malcolm maybe, and that information flowing between all of the different forms. So we need everybody joined up. And so again, it's that idea of, yes, you've got your patient record, you've got your care plans at the centre, but you must then be able to interface all of that information with the people who are actually providing care. So the patient, the hospital, their family, out into the community, forward and backward from the private care, and also into the third sector, which is often ignored. But actually third sector care, as the healthcare models are changing, is becoming increasingly important. And so we've got to be able to give them good patient information. So from our perspective, virtual medicine is on the brink of revolutionising, and it's a big word, revolutionising, an inefficient and unsustainable healthcare market. It is on the brink of making very significant changes. Changes to how that information is gathered, changes to how that information is stored and shared between systems, changes to how that information is stored and shared between providers, driving down cost, improving patient access, and improving patient care. So the big question is, when is this going to happen, now or in the future? So you may or may not be aware that a couple of weeks ago was Back to the Future Day. It was the date, the 21st of October 2015, in which in the second film, Marty McFly went to the future. We were promised hoverboards. No, we didn't get them, so I was a wee bit disappointed. However, the one thing, or well, actually there's a few things, but one of the biggest things that Back to the Future 2 actually got spot on was the video conferencing aspect. And so he had on all of his different screens, on his little tablet, on his watch, and all the rest of it, on the big screens on the living room wall, they had full communication. So actually, this is more close to where we are today. So the building blocks are there. We've got good telecoms networks, even increasingly out to very rural areas. We've got good software stacks that make this good quality, reliable communication. We've got increasingly good software stacks in healthcare information. The rise of HL7, the rise of FHIR, to make sure that that information is shared together. So the building blocks are all in place. We've also got good and improving acceptance, heaven help the proctologist. We've got increasingly good acceptance of remote and virtual care as well. So in the US, they say that 70% of patients are comfortable communicating with text, video, and email. So it is actually gathering significant pace. My mum and dad have been able to Skype me when I'm out here, and so I always take them as the benchmark. If they can do it, anybody can actually do it. So a couple of case studies to finish. Focus Cura is an interesting Dutch, Netherlands-based organisation providing remote care for the elderly. And they've got two main aspects. So one is home measurements. So you can put your blood pressure cuff on and it's uploaded directly to their servers. And what they will do is they will then do trend analysis. And if they find through that automated upload of the information that there's something askew, that there's maybe been a deterioration in your condition, they will then automatically start a video conferencing session with you saying, oh right, Mr. Jones, we've noticed that your levels are a wee bit higher, a wee bit low today. How are you feeling? Would you like us to dial in your clinician and the clinician can then join in a 3-party call with that patient. So it's much more, it's back to that idea of little and often constant, consistent care, monitoring of the patient. It means that that patient hasn't had to go in to the outpatient clinic just to get a blood pressure cuff fitted and to be back out the door 2 minutes later. But it's taken them 2 hours because of travel time. It's something that they can do every morning. So they've got targeted programs for heart failure, heart disease, etc. And what they say is that this has resulted in quantified metrics that say they have 26% fewer ER visits, 28% less hospital stays, and a very high level of patient satisfaction because it's very easy to do. You put the cuff on or you stand on the scales, it Bluetooths to your iPad and up to Focus Cura. The second one then is virtual visits, and this is where it's Skype with the patient. It's, how are you doing today, Mr. Jones? How are you feeling? How have you been eating? Can you show me your pill box? All the rest of it. Very interesting is that they have 85,000 virtual visits a month, but it's the average age that catches my eye. Because we tend to think, oh no, the elderly people couldn't do this. My mum and dad are 60. Oh, they wouldn't be able to do it. Average age here of 79 for a patient. So the technology is making things happen because technology is getting easier. When you look at an iPad, beautifully designed. I am a Mac fan, obviously, but they're easy to use. You press the button, you put your cuff on, off you go. You press your button to talk to somebody, and they're there in an instant. So the technology is easier to use, which is also leading to a higher level of acceptance. And from this, they reckon that 70% of patients said that their quality of life has improved, and they reckon savings of between 30 and 60 in travel time and costs for the patients as well. So a really big win there. The other one is Vital Pack. So they are vital signs measurement. They're working in around 600 wards across 46 hospitals, 5 million sets of obs per month, and it's workflowing so that they can track the observations and do workflowing for interventions. And some very interesting statistics from them. So they have seen a 15% mortality drop, equating to 700 deaths avoided per year in 2 of their hospitals. So 10% length of stay, and again dropping cardiac arrest and unplanned ITU. And a very interesting one, by measuring the stats and by measuring what's going on in the hospital, they have seen a 90% reduction in neuro outbreaks. So being able to see, right, there's something going on in that ward, there's a hotspot of incident there, shut that ward down for now, stop it from spreading on to others. So much more proactive, preventative care. So in terms of virtual medicine and pathology and all the rest of it, from our perspective, is your system going to be connected or is it going to be monolithic? The ones that are going to survive, the ones that are going to capitalize on the coming change, are the systems that are going to be connected, where their information, pathology information included, is available into the patient record and between the providers. The systems that are going to succeed are the ones that provide mobile interfaces. And it was the gent from Coventry and Warwick yesterday. It was yourself, wasn't it? Yep. Your remote reporting. So the ability for your workers to be able to work from home to actually do the reporting on the pathology. The ability for, if I was a clinician at this conference and my junior rang me, to be able to get my iPad out and look at the patient record and have that information available. And then the organizations that are going to survive and are going to thrive in this environment are the ones who are encouraging collaboration at the people level as well. And obviously recognizing that pathology is part of the wider team, so we've got to make communication in with the pathology team faster and easier. We'll have workflow and orchestration of events to avoid wastage of resource, to avoid all of those unnecessary, as we had in the stats yesterday, all of those unnecessary pathology requests. Well, if the system is able to say, you don't need a pathology request for this, it's X, Y, and Z, we're going to be reducing the resource wastage as well.
Fast-paced industry with the desire to deliver high-quality, efficient care for every patient, care providers need access to IT systems that are intuitive, flexible, and powerful. The Evolve mobile-enabled healthcare platform is built for iOS, enabling access for all trusted parties providing care to patient information that is complete, accurate, and available wherever their care takes place. On the hospital campus, in a patient's home, or at an emergency scene. Providing access to scan-to-start patient records on iPad alongside electronically held information gives the clinician a complete view of the patient history, enabling well-informed decisions. With flexible electronic forms, care providers can capture new patient information consistently and accurately on iPad, iPhone, or iPod Touch, and pass that information to the right people at the right time, enabling collaborative patient care. We are helping healthcare providers and technology partners innovate, building solutions to respond to an ever-changing healthcare market, evolve, bringing clinicians, patients, and their information together for better care.
So that's what it's all about. It's about having the solutions in place so that the information that you capture is high quality. It's about flowing that information to the other systems. So rather than just having another silo that you have to log on to get that information. And it's about flowing that information to the right people at the right time. And it sounds simple, and it's what we've been promised for years, but actually we firmly believe that now the building blocks are actually in place to properly make this happen, to really accelerate those changes and to bring about the reduction in cost and the improvement in care.